We want to get right away to our guest because this is a really important topic. It's always an important topic, and that is the topic of we talk about an epidemic, a crisis. We really have a crisis of overweight and obesity in our country and the ravages of that. We want to discuss that with Dr. Andrew Wheeler, who is a surgeon with MU Healthcare and treats all kinds of conditions like this, as well as some other things too. But we want to talk with Dr. Wheeler, and we want to talk about the various options for surgical treatment and how that all plays into a whole comprehensive approach, because I think we're all watching the scale go up as we shelter in place and eat comfort food and are more sedentary.
I heard something funny the other day. It said we're either going to all be pregnant in 9 months or we're all going to look like we're pregnant in 9 months.
That's an interesting
How you doing, Dr. Andrew Wheeler? Good to make your acquaintance. Thanks for being with us.
I'm good. Thanks for having me.
So, are you talking us from home? Are you sheltering in place here? And I guess your volumes are a little lower now. Have they cut back on your surgeries a little bit or not?
We are. I am currently sheltering in place in the office. We're doing a lot of telehealth visits.
Oh,
so we've shifted our entire clinic practice to telehealth, and so it's been a good opportunity to keep keep patients moving through the process during this this challenging time.
Yeah, and you talk about the process. I think a lot of folks aren't familiar with the road, the pathway to having a surgical procedure to address obesity. But why don't we talk about that? I mean, first of all, let's define what it is exactly, the kind of patient population that we're talking about, who it is that you're addressing in your practice, and then maybe we can, after the break, we'll sort of introduce it here with, what type of patient might come and see you, maybe referred from one of our doctors here at the hospital or for others around the state. And then after the break, we'll talk about that little virtual, pathway to getting into the operating room, if that's the right thing to do. Go ahead.
Yeah, absolutely. So when we talk to people about, who's the right candidate, the reality is that we still use, quite out-of-date recommendations from the National Institutes of Health that was put out in 1991. And part of the reason we use that from a practice standpoint is that's what the insurance companies and the governmental payers still look for. When we talk about clinical indications, we've changed that, but getting people to pay for it, that's a whole nother, getting insurance companies to pay for it is another deal. So we currently still use the criteria of a BMI, this is for insurance, a BMI greater than 35 with a condition that's associated with your weight. And generally that's considered sleep apnea, diabetes, high blood pressure, or diagnosed heart disease. Or it's patients who have a BMI of 40 or more, which is roughly about 100 pounds over their ideal body weight. Now, we have a comprehensive program, so even people that are want to lose 10 or 15 pounds in a non-surgical method, we can still offer that. Okay, and so we have everything from non-surgical weight loss all the way through. And generally, we talk about the idea of people who have tried other conservative ways to lose weight and it's not been successful. And a lot of times people tend to fall back on that as being very crucial. But the reality is all of the patients that come in to see me have tried for years to lose weight and haven't been successful. And the main reason is that weight loss through diet and exercise, or even dietary programs, there's a lot of programs out there, but diet and exercise is a very ineffective way to lose a significant amount of weight long term. The body's not made to rapidly lose weight. If we could rapidly lose weight, starvation would also be a big issue. And the body's very fine-tuned to conserve energy, conserve calories, to conserve weight. And so in a situation like we are in our country where food is in abundance, activity has gone down, food is much more higher in caloric density, portion sizes are going up, what we found is that it's very, very difficult now to lose weight.
Dr. Wheeler, we're going to be going to a break, and after the break, we'd like to first go through the process of the non-surgical. If somebody comes in your office, what is the criteria? What's the non-surgical ways first, and then let's take us all the way through the process. Finally, at the end, we'll be getting to the different ways of having the surgery.
Sounds good.
We're talking with Dr. Andrew Wheeler, bariatric surgeon, and I think we should properly say a weight loss expert.
Yes.
It's not just about the knife and the surgery. That's a very, very important point. And if you guys have a question for us, because it's a problem that is here, it's everywhere.
Pervasive,
and I know
everywhere.
Many of you struggle with that. We all do from day to day. Give us a buzz, 465-7225.
And 1-800-748-7875. We're speaking with Dr. Wheeler today from MU Healthcare about weight loss surgery. But first, before we get to the weight loss surgery, please take us through the process when somebody comes in your office and they say, Dr. Wheeler, I want surgery. It's not working out for me. What do you say to him? What kind of counseling does he go through?
Yeah, so it's really not a burdensome, but a very thorough process that we do, and some of it is dictated by the insurance payers, and I keep going back to that because that's a lot of what drives kind of how we do things. But all of our patients have first have a psychological evaluation. Now, I tell patients, we're not doing this to see if you're crazy or not. We're doing this to help set the stage to make the appropriate behavior modifications to help you be successful long term. We a lot of programs have someone set in place, or they send them out to outside referring psychologists, and we do that some. We also have a behaviorist that works with our program specifically here in Columbia, and she does the majority of our assessments before surgery. Excuse me. And then in addition, we're continually building in more and more tools for patients after weight loss surgery to work on their diet and behavior. So the other thing patients do is they work with our dietitians. And so they work with our dietitians to modify their food choices. Because really, when it comes to obesity, to gaining weight, it's not simply what you eat. It's not simply a lack of exercise. It's also how we approach food. And so there's a lot of reasons that people eat besides just for nutrition. And part of being successful is addressing those things. Sometimes we because of stress, sometimes we because of boredom, sometimes we because of taste. And then there's a whole host of probably lifelong behaviors that are built from even when we were kids. How many of our parents told us, there's starving children around the world, you better eat everything on your plate. And the reality is that simple behavior of not ever wanting to waste food probably causes us to gain weight because we don't ever leave food behind on our plate. And so part of this process is really working on helping people change behaviors to be successful long term.
You talked about behaviors and old habits being hard to break. It's interesting. On the one hand, and I don't know whether you and folks in the audience have experienced what I have we've all had more downtime, I think it's fair to say. And a lot of us that are on that treadmill going 10 miles an hour, and we just ram the food into our face, and sometimes we chase the taste and we're not even thinking about it. Mm-hmm. I find my wife's an awesome cook and cooks very healthfully. And I do really good now, sitting at the table, and I eat my portion. I'm more mindful, and but then I find that an hour later, I start to think about the next day, and I'm getting stressed, and that's when I want to get out the popcorn, So on the one hand, I think there's an opportunity with this sheltering in and people slowing down a little bit to be more mindful of why we're eating and when we're full, and hey, why do I keep eating even though I'm getting messages that I'm full? But on the other hand, fighting that need for some kind of comfort and running to the food, like many, I think, do, for a source of comfort. It's sort of an interesting tension right now, isn't it?
Yeah, it really is, and that you kind of addressed one of the behaviors that we work with patients on, and that's the snacking, grazing, or probably the biggest challenge for people trying to lose weight is eating after dinner. That late evening snack, because the body is not designed to eat and then not move, and so when we eat and we see a surge of the insulin produced by the body, and insulin causes a whole host of things, everything from production of fat by the liver to the storage of fat into the fat cells. And so when we see a surge of insulin and the body then takes in all of that stuff because we're not able to burn it, we're just storing those calories. Simultaneously, we see the normal cortisol levels, which drive our metabolism, going down later in the evening before they bottom out in the middle of the night, before they start picking up when the next day begins. And so we have this combination of active storage of energy energy combined with a lack of burning energy, and so really that late night eating can be very difficult, for weight loss.
I've been reminding a lot of my patients, Dr. Wheeler, that boy, if you think what up here in northeast Missouri, everyone knows how deer fatten up, right, going into the winter, and so do all animals, all mammals that have to make it over. And boy, their cortisol levels are surging during that time, and they are just packing every calorie into fat stores to get them through the winter. Well, I mean, not only is there that diurnal variation you mentioned, but right now, I mean, who isn't stressed and who doesn't have a higher than average cortisol level? It's a perfect storm right now, and that's why I'm so glad we're visiting with you, because people really need to be mindful of that. What kind of foods, given the choice and given the will for people to maybe make healthier selections if they are grazers by nature, what are some things that you would advise folks to substitute instead of the late night ice cream or after dinner, like I've been doing on occasion, getting up and having a little popcorn? What are some of the options that might be considered?
Well, when we talk about eating throughout the day, we really encourage people with a lot of high protein foods, high protein snacks. We know that with or without weight loss surgery, but the higher protein, higher healthy fat foods tend to create what we call satiety, or feeling of fullness longer. And there's a lot of different mechanisms the body uses to do that. But then when we move into snack foods, eating a lean chicken breast that may have 250 calories and 20-some grams of protein is great during the day, may not be a great snack right before bed. And so we really want to encourage people, if you're just having that craving and to consume something, to really work on those things that are fairly low in calories. Some protein's okay, but the things we really want to avoid are the high carb snacks. And so I usually tell people, if you have to open a bag to eat that food,
right,
then that's probably not something you want to go after, right?
Avoid things in crinkly packages. My patients hear me say that all the time. Not good. And you know what? Aren't you glad, though, that more and more, even on restaurant menus, I mean, I know there's a lot of political back and forth. Oh, should people be mandated to put that on their menus, and it's expensive? I get all that. But I really appreciate seeing and learning to read, and I think more and more folks are learning to read the caloric content. Yeah. And if you look at some of the things on those snack foods, like you just mentioned, it's frightening. I mean, it is. Oftentimes, I've been, who hasn't gone shopping when they're hungry and regretted it later? Right. All you have to do is look on the back of a hand-size pack of, pick your potato chip or your chip. My gosh, 250 calories for like 8 chips or whatever. Are you kidding me?
That's why I stay away from the big bags. Get away from the big bags. Go to the really small ones.
Hey, well, let's talk a little bit about, you mentioned that the body is greedy for calories and loves to hold on to them and loves to hold on to fat mass that's been built up. We hear about, and I've read about and heard in the past in my scientific endeavors, about the set point. Can you talk about why it's so difficult as people put on weight to then really make drastic changes? Does the body sort of have a thermostat that gets adjusted and stays there or wants to stay there? How's that all work?
Yeah, and I don't think we clearly don't fully understand. I'm convinced we probably don't even remotely understand, how it works. But there's several things that work against a person trying to lose weight. So one is the person's underlying metabolism, right? And when I say metabolism, how that person processes, burns, and stores calories that we consume. The other one is what drives us to eat. Now, we've talked about the behavior, but we also know it's not simply that people are just undisciplined who struggle with their weight, but the body also has a very complex mechanism of hormones that drive hunger. And then also drive the storage of calories. So, for instance, when you're hungry, you haven't eaten for hours and you're hungry, one of the reasons you're hungry is there's a hormone released by the stomach called ghrelin, and ghrelin causes you to be hungry. We call it the hunger hormone. And it's one of the reasons that when we don't eat, we get hungry, and then that also drives us to eat, so therefore it makes it harder to lose weight. There's also dozens of other hormones that contribute and to play into this as well. At the same time, there are hormones that cause you to not be hungry. Okay, there's one, the classic one is called GLP. GLP-1 is a hormone released by the cells at the end of the intestine, and we think it's oftentimes released in a response to the exposure to fat and protein to these cells. It's one of the reasons we think that the weight loss surgery, especially the gastric bypass, works so well is because GLP-1 levels go up after these procedures. And when GLP goes up, it does a couple things. Number one is it sensitizes the body to insulin, so your body doesn't have to produce as much insulin to be effective, and so it also, with less insulin, it's one of the reasons that diabetes is so profoundly improved after weight loss surgery. But GLP also causes you to be less hungry. So much to the extent that there's a whole line of medications now that are out there that are what we call GLP-1 agonists. They mimic GLP-1, and they're used for diabetes, but they have a secondary indication of weight loss. And so it's a big area in the pharmaceutical industry for diabetes and weight loss right now. But as I referred to earlier, the body also changes how it processes and how it stores, and it's very adept at not losing weight. And so that's why a lot of times people find that they'll start a diet, they'll lose weight, they'll feel great, the pounds are coming down, and then it stalls out. Lose 10 pounds, lose 15, maybe lose 20 pounds, and they're like, man, I can't budge. And we even see that sometimes after weight loss surgery, although the operations are so profoundly effective that usually they overcome that. But that's very common. People stall out. And so a lot of times what I encourage people to do is to change things up. Don't just stick with the same diet over and over. There's a lot of different diets that work well. And sometimes I think by confusing our bodies and not letting our body come to that static place, we can actually achieve some more weight loss.
Dr. Wheeler, we need to go to a break now, but let's talk a little bit more. Let's talk about the actual surgery and how weight loss, how these surgeries actually do address the hormones that people are having problems with after the break.
Sounds great.
Welcome back to the program. We're having a great discussion with Dr. Andrew Wheeler, a weight loss expert. Got his bachelor's degree in nutritional sciences, so certainly knows the ins and the outs of weight management, and then decided to take it on steroids and become a surgeon and fix it surgically when that's the right thing to do. And we'd like to pivot to that, Dr. Wheeler, if we may. You talked about the hormones and the gut hormones, and we now know there's this whole complex series of hormonal interactions in our whoever thought, when I was in medical school, whoever thought that the intestine would be a hormonal organ? I mean, I just wasn't on our radar screen back then very much, and now it's, of course, a whole field. But let's talk about the various surgical options. When folks have gone through your comprehensive program, they've had psychological evaluation, behavioral modification, they know how to eat, they know how to be active, and now it's time for surgery. There's a lot of different options out there. What are some of the low-hanging fruit surgeries that you can get a fair amount of bang for your buck? Let's just go through some of the different options on that surgical smorgasbord and talk about the pros and the cons, okay?
Yeah, so we really have three operations that we do now. Two that are predominantly done, and one that is less commonly done, and that fits with kind of trends across the United States as well. The most common procedure we do at the University of Missouri is the gastric bypass. In the United States, the other procedure, the sleeve gastrectomy, is more common. From kind of tradition, even before I came, et cetera, there were a lot of gastric bypasses done, and so when family members, friends, coworkers, know someone who had a procedure, that's where a lot of times they tend to go, and so we do a lot of gastric bypasses. Gastric bypass involves making a very small stomach pouch from the normal stomach, and then connecting the intestines to that to allow a place for the food to pass from that small stomach down into the rest of the intestines. Part of the byproduct of that is that we bypass the majority of the stomach and the first portion of the intestine. And so we think that there's some metabolic improvement of a person's metabolism and how they deal with calories through that. The other procedure, the sleeve gastrectomy, is quite a bit different in that we don't change the intestines at all, but we go in and we divide the stomach along the length of it and create almost like a banana shape of the stomach, taking out about 80% of the stomach. And so, although that sounds like a lot, there's still adequate stomach for a person to be able to eat the calories they need to maintain nutrition. And then the last procedure is almost kind of like a combination of the two in a way, is we do a sleeve and then we bypass a lot of the intestines, more actually of a bypass than the gastric bypass itself. We call that the duodenal switch. And although a little bit higher risk profile for this procedure, it's profoundly effective, especially in people that have significant diabetes.
So it sounds like, I mean, whenever we surgeons talk about different procedures with folks, there's always a risk-benefit analysis, right? And so
Absolutely.
How do you guide folks to deciding which is best for them? How does that discussion go?
Usually the way I talk is we first really get into a person's medical history, and then also what are they wanting to get out of the operation. There are some conditions, some medical problems that prevent a person from having one operation or another. Okay, so as an example, in some people who have reflux disease, the sleeve can actually make that heartburn or acid reflux significantly worse. So in that case, we may look at a gastric bypass more. Likewise, there are some people who have a lot of significant medical problems. We're talking about people that may be on dialysis or have liver cirrhosis, people who have severe congestive heart failure, require home oxygen for COPD. And a lot of these folks out there say, "Oh, well, I must not be a candidate. I'm too high risk." And really, there's not too many people out there that are so unhealthy, have so many severe medical problems with their health that we can't do weight loss surgery. However, sometimes those people that have a lot of those severe medical problems, we tend towards the sleeve more because it's a quicker operation. They're in and out of the operating room oftentimes in about an hour. The recovery is a little bit quicker, and there's less of a chance they'll need another operation down the road for various things. And so we kind of help tailor the operations to the person's health. Now, the vast majority of people, I would say, don't really have a strong contraindication to one of the procedures. And then it really comes down to me kind of working with that person and helping to understand, what are their goals? What do they want out of this operation? What do they want for their life? What are they wanting to change? What are they wanting to improve? And so it's really trying to tailor that operation to each of my individual patients and what they need and want. And some people it's they say I want an operation that I have the lowest chance of having any sort of long-term side effects. Sometimes people are saying I'm okay with the risk of some of those side effects, even though they're low. You're telling me they're low. Their major complications with these operations really are about 1% to 4%. Total complications, probably including minor things, maybe 5 to 10%. So over 90% of people go through this and do great. But sometimes people are like, look, I understand those complications, but I want to maximize the chance that I lose as much weight as possible. And then we look at other, we look at one of those operations. And so we really try and tailor the operation to what the person's wanting to get out of it.
Yeah. It's interesting. You hinted before that the eligibility from a financial standpoint is determined these days by insurance. And I think I was reading between your lines, and I think I agree with those in between the lines comments, that perhaps we would be wiser as a society to think about maybe doing these operations sooner, before people develop full-blown diabetes, before they had arthritis and needed both knees replaced. And that, given the great efficacy of these, and I understand these procedures, especially the bypass, have longevity, right? I mean, this really, it's not like you get the operation and then, 5 years later you're back to your space. People tend to do very well with these. Do you get a sense that we should be doing these a little sooner than we're bound to do them because of financial reasons?
Yeah, we're seeing a movement. Unfortunately, in the United States, we're much more conservative for a lot of reasons. But we see some of the South American countries and some of the European countries that are actually really dropping the bar on the BMI and doing operations even with people in the BMI range of 30 to 35, especially for diabetics, with the idea of if you have someone who has new onset diabetes and their BMI is 31, 32. Right now, the typical insurance company in the United States isn't going to pay for that. But if you do a weight loss operation, their diabetes goes away, we may have the opportunity to save a person from a lifetime of all of the complications that can happen with diabetes, because we know that in so many people, diabetes is a progressive disease, and as it progresses, it leads to a host of end organ damage, from the kidneys to the vascular system to heart attacks to strokes. And to loss of vision and nerve damage, and if we can stop that early on, and in early diabetics, so people who have new onset diabetes, they don't have that refractory, progressive diabetes yet. The cure rates that are putting the patients into remission is higher than 90%.
Wow.
When we talk to severe diabetics, people who are on significant amounts of insulin, although they drastically improve, the remission rates are probably less than 50%. That being said, even someone who, I have people that walk in, have a gastric bypass, taking 100 units of insulin a day, and they walk out of the hospital. Now, they've not lost weight at this point, right, other than a little bit of weight on their preoperative liquid diet. They walk out of the hospital off of insulin. And so there's something that happens in these operations that so significantly changes how the body deals with these gut hormones and everything else that can take away their diabetes, or at least drastically improve it, to the point where they go off tremendous amounts of insulin right away. But to your point, the earlier people, get control of their health and their weight, the better they're going to do long term.
Dr. Wheeler, could you tell us what happens post-op? Okay, so the patients had the surgery. Do they go through a process then of checking in with you, or how does that all work?
Yeah, so one of as the director here, I do a lot of the complex revisional surgery, and so about a third of my practice is dealing with patients who have had previous weight loss operations. They're having issues, and sometimes people do gain weight back, and almost every one of those patients tells me, especially that have had it, their procedure more than 15 years ago, they say, "Wow, this, there was no education for me after my first operation." They're like, "I know it's no wonder it wasn't effective. I just didn't have any education." And so, what we've tried to do at the University of Missouri is really build, the premier, weight loss program, definitely in the region, if not in the state, where we have a comprehensive program with surgeons, with nurse practitioners that do medical weight loss, with dietitians. We use class. We have support groups. We have now online Facebook Live support groups, so that people that can't make it into the office can log on and still have that interaction with their peers, other people who've had weight loss surgery, as well as the professionals I work with. And I have a tremendous group of people, to work with here that are very well talented. We're building out even behavioral and / dietary classes for patients that they can also do online. If there's a silver lining to the cloud of the coronavirus, it may be the increased use of technology in healthcare. And so we're really moving the bar in terms of using not just telehealth for visits, like we've been seeing patients every day since this has started, but now we're also trying to build out resources that patients can use more at their convenience. So a person that comes from Scotland County doesn't have to drive the 2 hours or whatever to Columbia to come to a support group. They can log on, get on Facebook in the evening while they're getting dinner ready, and they can interact with our dietitians. And we have some wonderful dietitians, and I'll try and follow along with Facebook as patients are posting different things, and it's amazing. Usually it's not but a few minutes, it seems like, and a patient's posted a question, and my dietitians are right on top of it, answering that question, encouraging them, helping them find the right resources to be successful. And so we've really tried to build something that is not just to get people up for surgery, do their surgery, and say, "Okay, hope you do well, good luck with your life," but really partnering with patients on this lifelong journey to be successful.
Well, we've had what a great hour we've had talking about weight management, weight loss surgery as an ultimate and probably more frequently justified treatment plan with Dr. Andrew Wheeler at UM Healthcare. The number to make an appointment is 573-882-5673. Can folks make their own appointment, Dr. Wheeler, or is it by referral only?
No, they can make their own. You can. There's a couple different things you can do. You can go on the website and you can click to request an appointment. You can go on the website and you can fill out the. We kind of have a question thing, helping people understand. Are you ready to? Are you ready to proceed on this journey? And they can fill that out, or they can call the number the 573-882-LOSE LOSE or 5673, and they can call and they'll set up an appointment with the surgeon. First thing we do is we verify to see if you have insurance benefits. If you don't, we talk to you about different options that we have. And if weight loss surgery is not right, we also have a very robust medical problem we can get people plugged into as well.
Oh, that's super good. Well, it's a fulfilling role that you play, and I think it's going to be an increasingly important one. I imagine in a pre-COVID world, you probably got more hugs from your patients than anyone.
Yeah.
And now that's just got to be elbow bumps, right? I mean, boy, what a shame.
That's right.
Hey, thanks for being with us. We really do appreciate it, and
Thank you, Dr.
we
Wheeler.
continue to do the great work down there. Thanks so much.
Thanks so much. Thanks for having me.
Take care. There he
Bye.
is, Dr. Andrew Wheeler. And it is really rewarding because talk about modifying folks not only metabolically but psychologically and socially. It is a quality and a quantity of life, literally. I mean, we've seen in the last couple of years reports, unfortunately, bemoaning the fact that for the first time in generations, the life expectancy in America has gone down. And that's sad.
Right.
A lot of it relates to our lifestyle, which has resulted in conditions related to weight management. So super important that people pay attention to this. And again, the number for Dr. Wheeler's office there is 573-882-4141. We'll take a break, come around on the other side of the corner there, and talk a little bit more about COVID. If you have any questions, why don't you give the numbers again?
660-465-7225 and 1-800-748-7875.